My name is Rosie Beacon. I'm the research manager at Reform and head of health. It is my absolute pleasure to host this panel on health and how we can use data better in the healthcare system. The NHS is often considered in a state of polycrisis, and it's becoming increasingly clear that policymakers need new answers to new problems. And data and the intelligence it provides is clearly one such answer. And indeed, there's little dispute that data can transform how healthcare is delivered, and there is no shortage of how it can be used, whether it is to bolster research capacity and in turn developing cutting-edge treatments, or whether it's to enable better decision-making with giving us a better view over population health data. And the NHS specifically is in quite a unique position. It's a universal, publicly funded healthcare system covering 56 million people. And the single-payer nature of the NHS and past innovations gives us a strong, rich view with longitudinal data. And this can have a remarkable impact on our ability to deliver care. But there is substantial structural heavy lifting that needs to happen before the potential of data in healthcare is fully realised. Data is often fragmented, it can be of a poor quality. I do think that while there is a clear case for optimism, this should not take away from the important and often difficult questions that need to be asked in order for many of these innovations to come to life. And some of these questions are structural, some of these questions are logistical, and some of them are ethical. And some of the answers are in recruitment and skills, as we touched on in the last panel quite extensively, whilst others are around infrastructure, and indeed some of them are just how practitioners enter data. So it is therefore rather convenient that we have put together this excellent panel with lots of experts to walk us through what they identify, what the biggest problems, but also what the biggest opportunities are for data in healthcare. So we have Zoe Keddie, who is the Chief Digital Information Officer at South London and Maudsley NHS Foundation Trust. We have Ben Goldacre, who is the Director at the Bennett Institute for Applied Data Science. We have Dr. Axel Heitmueller, who I only saw 2 days ago, maybe like 3 days ago in my previous role at Tony Blair Institute, who is the Director of Discover Now and Managing Director of Imperial College Health Partners. And we also have Konrad Dobschuetz. I hope I pronounced that correctly.
Wow.
Who's
the
his
name right, so that's okay.
He was the National Director of the NHS Innovation Accelerator and Chief Enterprise Officer at UCL Partners. So an absolutely stellar panel. I'm really looking forward to hearing what everybody has to say. So let's go through some opening remarks. Zoe, do you want to kick us off?
Yeah, so I should start by saying I'm relatively new in my role in South London and Maudsley. I've only been in post just over 7 months now. And I really have come in at the sharp end of the wedge when it comes to data. So my previous role, I was leading population health management in North Central London, and I'm very proud to say that we created one of the most advanced near real health time platforms in the UK for population health management. And I think one of the successes behind that was because of COVID. COVID, I think, in some respects, gave us a real appetite for data sharing. Everybody wanted data at point of care. There was an immediacy, nothing like a pandemic, to actually encourage people to share data. However, as soon as that pandemic mentality was over, that data sharing, we regressed. We went back into slightly entrenched ways of thinking, distrust. There was no real need to share data in the same way. But I had this amazing system appetite for data sharing, and I could see what it was doing to the residents of North Central London. I was able to identify, for example, who was living in a multiple occupancy household by using unique property reference numbers. I could then see there was high risk of COVID infection, who hadn't had a booster, what their first language was spoken, where I need to do some community faith groups, that real power of data to drive improved health outcomes and system transformation. Then I moved over to South East London. Very, very different quality of data. Very poor data sharing in comparison. And also a very different group of service users and carers. People with a high mistrust of sharing data, despite the fact that they can understand the benefits of data being shared. I'm also in an area where, I'm not sure it's something I'm proud to say, but South East London has one of the highest incidents of early onset of psychosis anywhere in the world. If I know that, surely I should be using data to put interventions in place to prevent that. I should be putting targeted services in place to help that population. I also know I've got high incidence of deprivation, high rates of minority ethnic communities who are at the highest risk of serious mental illness. I'm really fortunate to work in a trust where digital, I've got huge amounts of digital. I've got RPA looking at my referrals. I've got a private 5G network in one of my hospital sites. I've got the use of VR for dementia and eating disorders. And yet, when I look at the data quality that's contained within my EPR that would allow me to make some of those decisions, I struggle to find my ethnicity data. I struggle to find out the smoking statuses of my population that would allow me to develop some of those services. And I also struggle with the fact that I've got clinicians who talk about data. They're so passionate about wanting to improve the health of the population, and yet they don't understand data. I can put an SPC chart in front of somebody and they can look at me quite blankly as if to say, now what do I do with it? What do you want me to do? What does it mean? We collect more data than we actually need as well. And I know this for a fact because unfortunately, we were one of the trusts that were a victim of the cybersecurity attack back in August last year. We had no EPR. So we went back to collecting basic demographic patient data. Wasn't easy, but we actually managed to realize how much excessive data we actually collect, how much we don't need. There's so much noise in the system with data, we lose track of what we're trying to measure, what we're actually trying to do. One of my first weeks in the job, I went in to see a group of consultants, and we talked about data quality. And the response I was met with fascinated me. The response was, do you want me to save a patient's life, or do you want me to fill in a form? I want you to do both. It's not an either or. Data is important not just for that moment in time, but for the next person that looks at that record, the next person who's going to be treating that patient. But yet, data is not something that all of our clinicians in the NHS see as their core skill set. We know there's a huge lack in data literacy. When we recruit people, for example, we ask them, are you GMC registered? Are you registered with the RCN? Or whatever your professional group is. And we ask that very general question, can you work Word, Excel, all those things? Everybody says yes. We never test it. We do very little to support them with their data literacy and digital skills. And I think that is something that is really a lacking gap. And I think alongside that, our analytical colleagues, our BI colleagues, we know that it's very hard to recruit the skills and retain them within the NHS. More often than not, I could probably look at most of the leavers that we've had my last two NHS organisations. Where have they gone? Most of them have gone to the private sector to work on AI, ChatGPT, etc. So there is something about how we utilise the skills we have in-house, how we actually support our staff to develop, how we actually get to improve that data literacy. Because as I've seen in other parts of the NHS, when we do have that, it can be transformational.
Thank you so much, Zoe. I'm really intrigued actually by what you said about having to start again in some ways following the cybersecurity attack, because especially following the provocation from Ed in the previous panel around, if you built a system today, would it look like this? How did you find that experience of kind of starting again almost?
Resource intensive, I think, would be one thing, but also trying to get that behavioural change, remove the panic that we were in at the time. Obviously, thinking about sort of patient safety was the utmost in our mind, but also ensuring that we were able to provide high quality care. So really going back to basics of saying, what do we need to do our daily jobs? Let's forget about what was in the old system. What do we need now in the moment? And I think we've started to see that slight sea change in how we operate on a day-to-day basis. We're also seeing the complete panic that sets in As soon as the Wi-Fi goes down, for example, or we lose any connectivity across our systems, I've got the exec on the phone going, is it a cyber attack? So there is still something about how we change that mentality. But again, it's a slow process of changing, behavioral change is not quick. But I think we need to be more questioning about why we do what we do. When we record data, what are we recording it for? For what purpose? Just because there's a box, or because there's actually a real requirement that supports an outcome?
Excellent. That also wasn't me promoting cybersecurity attacks in order to reform the NHS, by the way. Ben, what do you have to say? What do you think?
Hey, thanks. Well, look, first of all, I come at this question from a lot of different angles. I'm a clinician. I worked at the Maudsley for 10 years. I run an institute with a series of research groups in Oxford who are all secondary users of data. I build infrastructure. So we built openprescribing.net, which you can go to and you can see what each individual GP practice is prescribing month by month, and you can go there now and do that immediately, spot opportunities for improvement in your own practice. You will join 20,000 other unique users a month. We also built Open Safely, which has got 58 million patients' GP records, all accessible for research and service improvement, and with the support of privacy campaigners and the professions who have historically blocked these kinds of projects. And then lastly, I've run at it from a policy perspective. So I did a review for Secretary of State, which reported 18 months ago, commissioned by Matt Hancock, reported to Sajid Javid and then Steve Barclay, and then a press release about our work from Vicky Atkins earlier this week. They're like Doctor Who, they regenerate very frequently. In my review, I described some of the unique challenges that data presents. First of all, the NHS is not a mammoth, it's a shoal. So you've got 160 trusts, 40 ICBs, 200 CCGs, million or two staff. Data is recorded in different ways, even when it's about the same concept, the same medicines, the same diagnoses, the same blood tests, all stored in slightly different ways. Secondly, you've got a lot of legacy projects. So medicine suffers from being an early adopter of data in some respects. So it's not a greenfield site, and you've got to deal with legacy projects which might have a lot of local technical commitment, but also sort of cultural buy-in and teams that might not be enormously excited about your brilliant new idea. Thirdly, you've got the problem of the data being very disclosive. So the same information about 58 million patients in England that you want to use to do research or to monitor and improve services, that same data set contains the most confidential medical secrets of every citizen in the population. So you've got to be really, really careful with it. And then lastly, this data is incredibly hard to work with. It's messy. For the most part, it's not created for research or service improvement analytics. You are parasitizing doctors' notes, which are an aid memoir for them to manage their patients. So in my review, I made a series of recommendations. First of all, we've got to stop sending large aggregated data sets out to multiple different locations for Barbara to work on her laptop in Berensfield and Martin to work on his laptop in Manchester. Instead, we've got to build the smallest possible number of secure platforms, and the users go to the data. We've got to stop sending the data out to thousands of different places, to tens of thousands of different users, all at different sites. Partly because that's a massive privacy risk. When you take names and addresses off the data, you do not protect privacy in any serious way. But secondly, it's a really inefficient way of working, because people are doing the same jobs around data preparation, data harmonization, data quality checks. But if 1,000 people or 10,000 people are doing it in 1,000 different places, and they're not sharing any of their information, their insights, their working practices, or their code, then all those moments will be lost like tears in rain. Secondly, data preparation is the great challenge of our age with health data. First of all, the same information stored in slightly different ways. Secondly, you want to prepare it into the kind of spreadsheet format that you can then use for your analysis or for your dashboards or your reporting systems. Now, to address that, you've got to take that problem seriously in two ways. First of all, you've got to have a national strategy, a workforce resource that's committed to that. Don't just pay for the final dashboards and the analysis. You've got to pay for the core underlying data preparation, which is grotty, unglamorous work. Secondly, you've got to adopt modern, open, collaborative approaches to computational data science, and in particular, you've got to share your code wherever it's been paid for by the public. You've got to make sure that whatever platforms you're working in facilitate the sharing of that code. I'm not a supporter of open code out of any kind of moral imperative for transparency in public services, although that's handy. I believe in open code because it's the best way to drive up quality, because it allows everybody to see where the problems and the bugs are in your code, to do quality checks. And secondly, it's a big driver of efficiency, because if I see that you've done the job well, I will be using your code in my project. And so that's a critical thing, which isn't just a thing that I say. That's now increasingly recognised in other parts of government, including ONS, who do fantastic training and capacity building around a brand that they call reproducible analytical pipelines, which is essentially all of that best practice. And then lastly, you've got to have training. So in the analytic community in the NHS, there are estimated, nobody knows, to be about 10,000 people who work as analysts. But there's enormous variation. Some of them are doing outstanding contemporary best practice, some of them really aren't. There's no standard job descriptions, no proper training, and so on. So my core recommendation there was a boring one. It was take the government economic service, government statistical service model, where you've got training, where you've got continuing professional development that meets specific learning needs, that is tied to job descriptions, where you have a parallel system of line management for your technical role, as well as for the policy or service role that you're in, and build capacity in that way. So that's what I thought, and that's still what I think. And apologies if it's concrete, but I'm impatient, and I think these things need practical fixes. I should say one last thing, if I have 40 seconds.
Yeah.
You may have seen on Friday there was an announcement from NHS England and DH. So Open Safely, which is the service that we built, grants users access to 58 million patients' GP records for research and for service improvement. We've just been signed off to now go ahead and start getting permissions to do more than just COVID research. And we've also got core funding to cover the service at its current scale, and we're hoping to grow it beyond that. So if there are people who want to work with GP data to look at the picture nationally, but you can also drill down to very fine-grained signals, then do please get in touch. Any email address you find will work.
Thank you, Ben. That was really, really insightful and very compelling and extremely practical, actually. So thank you. I was really intrigued from, a lot of your work in this space. Was there, I hate using policy jargon, but was there an example of really compelling best practice in your various travails, scrutinising the service and how data is used? Was there something you saw that you thought that has to be scaled, but we must find a way of doing this?
So I think the challenge, especially in the sort of practical service analytics community, is that there is so much good practice and not enough structure around disseminating it. So the clearest example I think I could give is from some of our own work. It's not my work, but you can see other people's good work in open prescribing. You can see that in some areas, if there's a warranted change in practice, adoption of a new treatment or response to a safety signal on a treatment, you can see that some regions implement the warranted change in behaviour instantly and suddenly in a very coordinated way. Some areas implement it very suddenly in a very coordinated way, but 3 years later. Some places never implement it at all. Some places you see a gradual improvement. And what you can see there is the kind of rather anarchic approach that we have to knowledge dissemination and to the use of data to spotting improvement. So if I tell you that Nottingham is weirdly good at responding quickly to warranted changes in prescribing in primary care, you can see that in the data. The question on how they do it has never been answered. I don't know. I've never been out to talk to them. But what you can see in the data is that there is spectacular variation. There are some areas that are incredibly good at spotting problems and fixing them, and some that are really slow.
Brilliant. Thank you. Axel, can I invite you to share some of your opening remarks?
Yeah, you asked for the challenges and opportunities, and I think you both have covered quite a lot of the challenges. I might throw one or two additional ones in at the end. Maybe let's focus a bit on the opportunities that are there. And so I guess I come to this also from different hats on. I run one of the countries and probably Europe's largest real-world evidence hubs in London, but I also have a policy sort of hat on. And then I guess we're all users of these services as well. So we all have experienced the upsides and downsides of how data and information is processed in our healthcare service. So if you take sort of three levels, if you like, of opportunities at the kind of patient level, Engage Britain last year went out and asked the public what the biggest issue was with the NHS. And, they spent a few weekends deliberating what it was. And in the end, it was a lack of communication. So the frustration that's there, that between different parts of the system, we don't seem to be able to link information, whether it's GPs and hospitals or other parts. And it's really striking because that is obviously extremely low-hanging fruit, that in other bits of industry, people have started to make some good progress on. But we seem to be unable to exchange even letters between hospitals and primary care in any meaningful way. That's getting better. We have an app now, an NHS app that has been downloaded, I think, over 30 million times. Doesn't mean it's being used by 30 million users. But if you open it now, there are interesting things that you can see. You can, for example, if you're lucky, you can see your entire history of primary care records. And as of this month and maybe over the next sort of few months fully, you will also be able to see some of the hospital records. That's a huge step forward, and there are very few countries in the world that can do that. And the side effect of this is, I hope, if we get it right, you alluded to COVID. Something very strange happened during COVID because we told several million people to stay at home. And several of them we had told by accident because their medical records were wrong. And so people started to engage actually with this information and corrected the medical records. I personally think we're sitting on about 60 million data cleansers in this country that could do the hard yard on improving the data quality that sits on EPR systems, etc., but we're not doing it. The app is an opportunity because if you suddenly see what's written up about you, you can engage in a way that, otherwise it's very hard. But take it a step further. So let's say you have a particular condition. At the moment, you have to rely on your care professional to tell you what the latest intervention is. Let's say you had diabetes and there was a new way of treating it. You would find out by accident, more or less, if you engage with a clinician. There's no proactive way in which we reach out. So you're very lucky every winter to get a text message to say that you might be eligible for a flu vax. But that's as far as we take proactive care. What if, on the app, it knew who you are, what conditions you had, and it proactively told you what best practice looks like? Rather than nice sort of sticking PDFs on a website, there was a dynamic knowledge management between NICE and the app and you knew what to ask for. That would also start to address this issue that we have in the UK, which is new medicines, new innovation is not taken up systematically. The adoption is extremely slow. If you talk to life sciences about what they don't like about this country, it's two things. It takes too long for clinical trials, and the work that Ben and others have done on getting actually research data organized, is a great step in that direction. But the other one is we're not taking up medicines quickly enough. Now, if there was a proactive way of telling you about what you might be eligible for, that would go some way of addressing that as well. So there's a whole range of things and opportunities that we have because we have a piece of infrastructure that's already there, which is the app. It's not perfect. It's currently basically a website run on a phone rather than an app. But people are busily sort of developing this. And then take it one step further even and say, for research, for example, how about it also told you about research trials that were available for you and your condition, your age, your gender, your ethnicity, and you could sign up on the app for it. You can already express preferences for research on the app, which is fantastic, and if you haven't done it, please do it. But this would take it even further, and you could automatically, sign up for trials, etc. So there's, at the patient level, we have the beginnings of infrastructure that could actually use data in a completely different way. So then we have committed as a country to create 42 integrated care systems. Right? So the NHS is going through a massive restructure, if you like. In theory, at least, there should be 42 places across the country that have some degree of freedom to organize care in a different way. Now, that requires a knowledge of the population. And I think, Zoe, you made some brilliant comments about the absence of even basic information that we have about our population. That was different during COVID, and I've seen brilliant examples of local authorities, for example, mapping literally house by house, street by street, the need in their population and going proactively out and find people that needed help. That is effectively the model that we need to run integrated care systems. You need what people call sort of a stratification of your population. You need to know who your customers are, right? And then you need to organize your resources accordingly. That requires a level of data infrastructure that we don't have. But it's not just the data. We probably have some of that data. It requires effectively the sort of characteristics of an insurance company, because these are small insurance companies. They need to run actuarial models. They need to understand the risk that sits in the population. We haven't got any of that at the moment. We haven't got the skills, we haven't got the models, we haven't got the mentality to really do proactive care. But that is what needs to happen at the local level, if you like. And then at the national level, we are collecting a lot of data at the moment, which is for performance management, right? So this is basically to tell people that their waiting lists are too long, for the Secretary of State to pick up the phone and call people on a Monday and say your A&E is too busy. That's the sort of command and control style model that we're running at the moment, which, my personal view is that's not sustainable and probably not. You can't run the healthcare system with a sort of long screwdriver from Whitehall anymore. It's too complex. So there's then a question of what actually the data does for the center. And if you think about it, we're pretty much the only country where you could have a proper actuarial model for the whole population. We could say something about the future health of our nation. We could have a health account, right? We could actually account for the health of the nation in the same way that we account for the infrastructure. Because as we also have seen during COVID, being an unhealthy, relatively unhealthy population, which we are in the UK, makes us a very poor nation, economically and otherwise. So what if we actually had a proactive, forward-looking view of the health needs of our population? We're testing now everyone for their genes. When you're born now, there's a genome project that will test every newborn in the country. That is tremendous data that we have as a nation that can be anonymized, doesn't need to be personalized, and you can use that to learn something about where you should make investments, etc. So there are huge opportunities for policy development as well. So if I can throw in one sort of barrier which hasn't come up yet, I agree with all the ones that have been put forward. I agree, this is actually not about data. This is not a data problem. It's not a technical problem. It's a problem of not having insights. So the healthcare system, having worked across sort of multiple domestic policy areas in the past, is probably the most data-rich environment that you can imagine. There aren't many other public services that have as much data. But we have almost no information. We have almost no insights other than the data that we collect for performance management, so-called performance management. Right? And for me, that is the biggest issue. It's not about data, it's about the lack of insights, which absolutely relates to points that have been made about the skills, but I think it's more fundamental. We're not curious. We're not curious in healthcare. We do not want to have the answers to the questions that Zoe have raised. We're not interested in what our population really looks like, because the model that we have is effectively a sickness model that sees the next patient. It doesn't reach out proactively. Right? I've given you some examples. So there's a cultural issue here that we need to crack first. We need to have an operating model and a culture, and then on the back of that, we can build the data and digital infrastructure. But it's that way round, and sometimes the NHS starts to build infrastructure without actually having a proper operating model, and no other industry would do that.
Yeah, that was absolutely brilliant. Thank you, Axel. The point around data and intelligence really resonated with me. I think so often we refer to data as if it's, an answer to solutions in and of itself, but data is a fact, it's a piece of information, it's turning that into something actionable intelligence that informs a decision, which is what makes it really impactful. I really just want to ask you a quick question on the proactive services. So I really love this idea of proactive services across government, but especially in healthcare. Can I add another layer onto it around things around wearables? And there is a big conversation in healthcare at the moment as to how you use wearables, particularly for chronic conditions. How would that tie into something around proactive services? Because it's one thing pulling on a set of data and saying you're eligible for X, Y, and Z. But what about something that's slightly more real-time using wearables? Is that something you've come across? Is that, something, a frontier of innovation that's happening in any of your research?
Yeah, I mean, it's definitely going on. Obviously, we're producing all this data all the time. I mean, you have a phone on you probably, and it's collecting a lot of information about you all the time. Finding a way to meaningfully put that into the healthcare system is the challenge, right? So I'll give you an example. For many years now, you could basically take your heart rate and AF sort of readings on the phone, right? I mean, you don't even need a separate device anymore. You can just put your finger on the little light on the back, and it gives you a one-lead ECG. I mean, it's brilliant, right? It's unbelievable. We're becoming our own doctors in our own sort of, labs in many ways. And COVID had other examples where we have done lateral flow tests over a breakfast table. The trouble is, for example, with the AF kind of detection, it spits out a PDF. It doesn't fully integrate into the EPR systems in primary care. It is an attachment that lives on your file. The attachment is not searchable. So brilliant technology that can do an ECG on a phone, but then the motorways are not built to integrate that information into the kind of mainstream health records. And unless we crack that, it's quite difficult. Now, obviously, we might actually come to a stage where people say, forget that. That will never happen, right? We will never have an interoperability, partly because the vendors, on the whole, behave in ways that are sort of slightly monopolistic and don't want to have interoperability because it's not in their commercial interest. So how about the patient becomes the integrator of all this data, right? So why not have a personal health account? Maybe the app is the front door to that. And I integrate all the data that I want, and I control basically the data that I hold, which then could also contain a lot of the kind of continuous data that we're collecting all the time. So maybe we need a bit of a rethink about, this whole issue of interoperability.
Brilliant. Thanks, Axel. Konrad,
Thanks.
I'm looking forward to hearing what you have to say.
Thanks so much, and apologies, I have to continue with the German accent topic. You're going to have to stick with that, that's okay. So just quickly, I've got these two jobs or two hats on, and in both of them, we come across sort of the data richness of healthcare quite a lot. The NIA is a fellowship that has 34 fellows, is free to join. It's centrally funded by NHS England and also through the Health Innovation Networks. The vast majority are digital health companies, right? So they work in that space. If I tell you that nationally about 5% of patients occupy over 80% of beds, and they are serial offenders, for lack of a better word, that data, those 2 points alone should help us to improve our healthcare system no end. But what do we do with that? Nothing. And that's the problem, and Axel was alluding to that. It sort of hits that barrier of, yeah, we know this, but then it can't go into a certain system, it can't talk to something else. So what I'm here to talk about today a bit is some of the reflection of the companies that we're working with, either as a UCL Partners Health Innovation Network or within the NIA, so the sort of voice from the ground, really, of companies that are trying to work with the NHS and struggle a lot. So some of the support that the NIA delivers is helping with DTAC and all of that stuff, but you'd be surprised how many companies have no idea that they need that and that they actually can't really work on the data side and integration side with the NHS, and that's your primary care, that's your ICS, that's whatever you name it, if they don't have that in place for their solution. So we've had a fellow, which I don't want to make advertisement for a certain company here. So we have one that they need 1.5 years to get that done, 18 months to have a tick box that they can work with and can integrate with NHS systems, which are, again, in secondary care, as you know, Epic and Cerner. We've got EMIS and the other lot in primary care, right? So that's disparity is already, or that issue of access is one of the biggest we have. And I'm not talking about market access. I'm not talking about all these companies that want to benefit from the data richness and ultimately benefit us as patients to risk stratify, to allow us to read our own healthcare record succinctly on the NHS app, to sign up for clinical trials. They're waiting. And these are not big US conglomerates. They're UK-based companies. They are paying their taxes here, they're creating jobs, but they can't get in. And they can't get in because the various integrations don't talk to one another. We don't have an integrated care record, primary, secondary care. It may come, who knows. Meaning that I'm half replacing here, and Zoe is the other half. She may know, but we don't. At least I don't. But that's something that should come, right? As a key improvement of actually allowing that exchange and allowing access for those innovative companies to make something of that data richness. One point I want to pick up on, and I have picked up on something you all have not spoken about, which is great, and I was hoping you don't, so it's mine now, is health inequalities and bias in data. So for about 30, 40 years-ish, if it gets digitized, we've been collecting healthcare data, right? If I give you an example, I've got a few, but 2 examples there from maternity. If a woman of black color is 4 times more likely to suffer complications in childbirth than if the woman is white. So that's, again, a nice stat you can all take away and discuss at your breakfast table tomorrow. But again, what do we do with that? The reason why that is because the data and the risk stratification done is biased. It's biased towards a white population. If you look at other maternity-related pieces, for example, I'm going to get this wrong now, I'm not a clinician, I think there's a SCORM system in maternity, and one of the questions is asking when there is problems is the shade of blue of the baby, if there is a oxygen issue. So if you wonder now if black babies get blue, they don't. They get a shade of pink if there's an issue. So that is point blank an issue with how data is being captured, how people being asked. And if you now imagine that's been done tens of thousands of times and then flows into our new data-rich NHS environment and all the funky ChatGPTs and all that jazz, ultimately you're introducing a huge amount of bias and inequalities into your data. So I'm actually a big fan, and this is my personal view, of scrapping it all and starting new, because we're sitting on a time bomb when it comes to disenfranchising more people in England and in the UK overall. We really are. We're all seeing this shiny new world, AI, and all that stuff. And I've heard speakers before talking about ChatGPT and creating code. That's all fine. But have you heard about the lawyer that got kicked out because none of the case studies quoted of ChatGPT were real? My better half, she's a nutritionist, she tried ChatGPT to pull together studies for a patient. They were not real, they were made up, right? So just beware. This stuff is nowhere near, because some of the data is flown in, some of the sort of capture is all biased. We're working with Professor Bola Ovolabi on debiasing data in the NHS. That's a huge sort of topic, and that's through the NIA. We found a few companies that can help us with that, and it is really addressing inequity that has been solidified in existing healthcare data. So we're trying to untangle all of that. And the big headline or the big sort of overarching piece of all of this here is, if we don't address that, if we don't allow equal access, utilizing data to the NHS for patients, we can forget about all of this. None of this will work. And people will ultimately, I don't know the English term now, when the things go further apart, everything will go further apart, and less people, a certain layer of population will have better access, like us lot in London here. It's all great. But then if you look at some people in the north that we're working with as well, and where there is a layer of disparities over one on top of each other, they're not going to have access anymore. And is that what we want, really? Is that what we want with all this shiny data? I don't think so. So I'm going to be the poker here today, because, it's not all shiny, new, and glamorous. We're going to have to do some of the groundwork.
Thank you. That was really interesting, and we welcome being poked on policy ideas. I thought that was really valuable, and I think this has definitely become a pertinent discussion, especially since the pandemic. But since this has become a bigger topic, especially around data, have you seen much progress around it? Because I don't dispute that it is still a problem, but has there been some progress in overcoming some of these biases, even if the data still remains fragmented? You know, is there, you know, a case of best practice, as it were?
There is. I'm not going to tout the company. So there's a few projects going on, also up north, where a company has taken apart existing patient data, all anonymized, but they looked for the. I'm not a data scientist, so I'm going to get torn to shreds now. But they looked at the sort of common denominators of race, gender, and all that stuff. So the things you can actually look at without the name, and they were able to identify different treatment pathways of race, gender, and so on and so forth, and speed of treatment and speed of referral. That was different by color, by gender. So they were actually able to dissect that in historical data and look at that's a problem. So, and as soon as you identify that that's a problem, you can actually then unscrew all of that and make sure you don't bake it in next time around, and you address that in the way you deal with patients. So because the big issue is that we're baking in all of this historical data into our new models, and that's the big worry, I think.
Yeah, definitely. It's really interesting to hear about that particular example. So thank you to the panel for some really interesting remarks. I'm now going to open up to the floor for questions. I will go to this lady first, who keenly put her hand up immediately.
But shut up.
Hi. So I'm Ellie Horwich from Newmarket Strategy. I actually had a question for Konrad. I really liked your... Sorry, you won't be able to shut up now. Which I thought was really interesting, which is that I think, you know, kind of people ascribe quite a lot of an aura of infallibility to technology, which I think ultimately people believe somehow absolves them from having or using their own brain to make decisions about tech, which I think is quite scary. So thank you for your remarks on that. My question was specifically about how do you think that, I guess, kind of different healthcare institutions should be dealing with legacy data, given that, you know, we can't really start from scratch and forget about everything else, as you suggested, could possibly be done. And how do you think potentially current big data programs like the Federated Data Platform or the SDE should be trying to deal with this, so that it's kind of done once and for all and not necessarily replicated again?
And I'm writing comments from the people that know what they're talking about.
Yeah.
Because, you know, out of my depth. So essentially, patient involvement is extremely important. So what we're going to have to do is we're going to have to really make sure that these projects and these initiatives are set up and they're co-created with the sort of slate of patients, for lack of a better word, that we're trying to address and that we're trying to actually make this right for. So I just voiced that in that trust in the North, they were able to identify what the problem was, but then you're going to have to involve patients that are affected by it, get their views, and actually co-create the solution for the problem with patients on board. So I think that's sort of the broader headline. And like Federated Data Platform, I can't talk to that. It's not my baby, so I'm not involved in that. But others here are, as I know. So you're welcome to talk about that. Historical data is what it is. So I agree, we can't throw it away, although it might be better. But what we need to do is we, again, need to have just an aware point that there is bias in that data and not take it for granted.
Great. Does any of the other panelists want to? No? Fantastic. Right, more questions. Oh, yes, let's go to this gentleman on the left here.
Thank you. So my name is Darius Ansari. I'm a consultant at Newton Europe. So we do a lot of work in the sort of proactive prevention space with local government and with health systems. And one of our reflections is that actually there's lots of great intent to do this proactive, preventative care, but they're afraid. They're often afraid to do it. And they're afraid to do it because they're afraid to connect data together. And then they're afraid to process the data. They're afraid to run machine learning algorithms, et cetera, to identify who's at risk of something. And that's often because they feel there's lots of different ways in which you can interpret things like GDPR. And then once they're able to do that proactive intervention, they're often afraid to make that contact in case they're contacting the wrong person, and therefore what sort of punishment there might be from the media or from the government. So I guess my question is, what role do you think the government, central government, has in playing in sort of reducing some of those fears so that local government, local authorities, health systems can actually progress on this agenda really effectively?
Thank you. Who wants to jump in, Axel?
I mean, I can make a start. I'm sure Ben has lots to say as well. So I think there are a number of things. So one, there's a lot of misunderstanding about what is permissible under the law and what isn't, which, by the way, is often also used as an excuse to not do it. But I hear what you're saying. I completely recognize there are lots of places that would like to approach this in a different way. So there's something about central government communicating what's actually permissible and what isn't in a much more meaningful way to places that want to do it. There is, however, there are lots of grey zones still in the law, and in many ways why we could get away with it during COVID was because there was an emergency legislation called COPI that allowed you to do all kinds of things that, in peacetime are not permissible. And that's a problem, and as Zoe said, I think we should probably, and people have, sort of looked at whether we should carry some of that into, steady state to make sure that we can carry on. But I do think that in London we have spent an awful lot of time working with the public and asked them about the trade-offs, right? So you have to basically set out a trade-off. So something might go wrong. We might contact you and you're not the right person, which, by the way, we did during COVID a lot. We told people to stay at home. You can't leave your house. I mean, you can't get more interventionist in many ways, and we got it wrong. But when we work with the public and present these trade-offs about the use and the risk and the benefits, the public is incredibly permissive. They draw a few red lines about what you shouldn't do with the data, but actually, when you take them on a journey and let them express the rules of the game, a lot is possible. And in my view, we're not doing enough of that. And we haven't learned the lessons enough from, Kero data and other sort of events. There might be another event this week. We shall see. But unless we get into this a bit more systematically with the public, then I think it's going to be difficult.
Ben?
I think the two problems that you raise are caused by the lack of coherent systems around data access and communicating insights. So the systems to get permission to access data are very slow, and they create an enormous amount of anxiety. And that's for very good reason, because the technical approaches we use to granting access to data are inherently very unsafe, traditionally. We take the names and addresses off. Very unhelpfully, a lot of people across the system have asserted incorrectly that presents some kind of meaningful barrier to re-identification, that it addresses privacy risks when it really doesn't. And so to manage the privacy risks caused by disseminating pseudonymized data, the system has had to rely on contracts, promises, delays, carefully evaluating the people, the project. If we build platforms where the user goes to the data rather than sending the data out to small sole traders like you describe, then those privacy risks are mitigated, the anxiety is mitigated, people can access the data without those delays because the delays are just there to manage the privacy risks of dissemination. I think you see the same lack of a functioning system when it comes to communicating insights back. Of course, people can always have missteps when they go straight to the Daily Mail and say, here are the 10 worst GPs in Cheshire or whatever. So you've got to be thoughtful about how you do it. But also, in the same way that you need a technical infrastructure to access and grant access to data, you also need a social machine if you want to go out and communicate insights to clinicians and services and improve them. And what we've got is a kind of patchwork of some bits and pieces of that across the system, There's a lot of best practice that we could lift up, but there are a lot of gaps. So for example, in primary care, we've got the medicines optimization teams. There's about a dozen people in every CCG. They'll be aggregating as we speak in ICBs. And their job is twofold. Firstly, use data to spot opportunities for improvement. And secondly, build relationships to go out and talk to people, push a graph under their nose. They know how to press the buttons of that partner in that practice or that locum in that practice. And what we need is to, first of all, level up, if that's not a bad phrase these days, to take the best practice from around the country and get everybody working in that way. And secondly, I would say we need to either expand that model or a very similar model to get people using data to address variation in care, not just for prescribing, but also for testing, referral pathways, inequalities, and so on. But leaving it to one or two people as sole traders going out and thinking, what do I do with this signal I've found? That will obviously go wrong. You've got to have systems and structures in place.
Thanks, Ben. Oh, yes, Zoe.
Sorry, can I just also add, I think there's a little bit of narrative that's maybe sort of a nuance here, which is around when you're saying proactive preventative care, we're looking at patient empowerment. We're trying to give data to the hands of those citizens to take greater control of their own healthcare. And yet there's also, this is sort of a conflict with the concept of clinical liability. If you have an algorithm that says, well, actually, do you realize you're now at 10% higher risk of developing some clinical disease, what is that individual going to do with that information? And if they choose to do something that causes serious harm to themselves as a result of that, where does the liability sit? You then get back into questions about data linkage. Where did that information come from? Who provided it? Who sent that information? And that's where I think you often get some of that hesitancy about people wanting to join the data up for the, the worst case scenario. And that, unfortunately gets inflated in some of our media.
Great, thanks. Oh,
I've said something controversial.
No, I just want to make a point. About 2 years ago, I think the King's Fund did a bit of a study about over 30% of people in the UK feel or suffer or feel they are digitally excluded from healthcare. So, I hate to be the guy that always says it's not everybody. And if we talk about patient empowerment and patient owning data, in 2018, when I was working for industry in pharma, we developed a blockchain project, and it was all hunky-dory in the States and lovely. But ultimately, will this work here, Axel, right? Will this work with that amount of people not even wanting to or not able to engage with healthcare digitally? So who are we excluding again? So that's a consideration which we're going to have to take into account. And I'm all for this stuff, 100%. We're going to have to do it, but the right way.
Yeah, just briefly, I completely agree. And we just did actually, a big project in London on digital inclusion, and I take some confidence from that it can be done. But I also want to say that just because it's not everything is for everyone. I think we have to get away from this idea that just because it doesn't work for absolutely everyone in the country, we shouldn't go faster with it if it works for some people. We then need to absolutely double down on the groups where it doesn't work. But it's not sort of, one-size-fits-all kind of approach, because at the moment it's a one-size-fits-all. And it's the lowest common denominator, really, that we're sort of running the system on. But I completely take your challenge.
Ben, did you want to come in?
Look, I was going to raise very similar concerns. Empowering individuals feels good, and it feels good in this room because we're the kind of individuals who would be empowered. But you've got to recognise that there's a risk that it might actually exacerbate some of the inequalities that you're working on and worrying about. And I think the biggest bang for buck is you've got to fix the basics. You've got to get the pipelines working. You've got to make the data accessible in a cheap and quick way where it's properly curated and DQ'd and harmonised where it can be pragmatically. Don't try and build the world in one go. And I think when you do that, you reduce the cost per insight. And at the moment, I don't think it will be the right time to do too many fractured, fiddly little projects with data that might sort of be waypointers for the future. But really what you want is to create a productive market where data access is much easier for everyone, and that requires platforms and curation, and it's boring.
Great, thank you. One more question we have time for. Ooh, who shall I go for? This is the difficult part of being a chair. I will go for this lady wearing the green top.
Hi, My name's Liz Dobson. I run a disease registry. So we love the way data's going. We love Open Safely, and very exciting to see the federated data platform coming along. We see the data is messy, but the data landscape is messy. So we often have what we call sometimes there's a mind the data gap. A lot of these initiatives are designed for around the big systems, EMISs, Cerner's, EPICs, but a lot of the chronic diseases we deal with are small, and there isn't a system. And of course, spreadsheets rush in to fill the void. So in many hospitals and secretary centres across the UK, you've got data locked in these not the big systems. And you've also got, solving these chronic disease problems, as the title is Personalised Care, you've got apps. 1,000 patient apps have zoomed into the scene as well. And they're offering services to patients, sometimes often to the clinicians in those data gaps. And they are sort of sometimes it feels like we've got a grey area of data where is it in the NHS or does it belong to the app company? So the questions here, because I'm sliding 2 in for the price of 1, the questions here is how do these small data gaps solutions, whether they're internal in spreadsheets or external as apps, how do they fit into this new world of federated data so that that data can be unlocked for research and benefit of patients, etc.?
Thank you so much. Who wants to come in first?
I can give a perspective from not the FDP, but from the sort of secure data environment perspective that we're trying to build in London. So, you know, in many ways, I see it as a sort of conveyor belt approach, right? I mean, there's some basic data infrastructure that needs to be in place to have the backbone, which is primary and secondary care data predominantly. We already have community and mental health care data in there as well. So that's the kind of backbone. But then there's a long queue of stuff that you could onboard, right? Like the random spreadsheet in, you know, TrustX. Or air quality data. So, you know, for example, in the past we have put air quality data in there because we were interested in asthma. But there's almost an endless number. And pragmatically, in London, we're driven by where the interest is, right? So if there's a client, either academic or commercial, that would like to work with this, then we would probably do it. And the reason for that is, unlike the US, we have these tiny amounts of money that last for 2 years, and then there's no certainty about what happens afterwards. So we have to be commercial actually quite quickly, and therefore have to go where the interest is. The advantage of that is also that on the back of onboarding this data, you can then clean it. Because if there's someone who wants to use it, generally in our experience, the data quality improves after the project, and then that value stays actually with the NHS data. So it is a bit sort of, you know, pragmatic, my approach to this, but I can't see a more systematic approach to it, given that there's almost no funding, and given that we have just raided the capital budget again a few days ago. You know, I think we have to leverage other investments, which I know you for example, are doing with the data that you have, and bringing sort of private capital into this infrastructure. But then, unfortunately, we have to sort of go with the pace and the interest of that capital rather than maybe where we want to go internally.
Great. Thanks, Axel. And thanks to all of the panellists for what was an extremely enriching, oh, mixed 2 words together there, enriching and enlightening panel. So thank you very much. I learned a lot.